Morning, everyone. So I know that I'm the person between you guys and a cup of coffee, so I promise I'll stick to the 15 minutes. For those of you who don't know me, my name's Jim Mcardle. I'm here with IQVIA, and for those of you who don't know who IQVIA is, we'll dig into that in a little second. I do feel that Roland had probably had a sneak preview of my slides, because most of what I'm going to say had probably already been said. Okay. So I am the strategy lead for IQVIA, sitting within our patient business. And IQVIA, I reckon I've been invited here today to really talk about the role of life sciences when it comes to innovation adoption. And the key role that, given that life sciences is a jewel in the crown of our economy, that's why we should be all looking to support. IQVIA is the second largest life science employer in the UK. We are a global organisation and we work across 140 countries and we employ 90,000 people, 6,000 of whom are here in the UK. We attract per year £2.2 billion worth of inward investment into the UK. There's four broad pillars in terms of what we do, and they're all relevant to the discussion today. So the first one, around 25% of our revenue is directly related to clinical trials. Why is that important? Because if we don't bring clinical trials to the UK, then we're not bringing medicine to the UK. And if we're not bringing medicine, then our patients aren't getting access to them. If you look in the last 10 years, we've had a steady decline in the amount of commercial clinical trials that have been brought here. We're now delivering 36% less clinical trials today than we were back in 2015, 2016. Last year, over 10,000 NHS patients were enrolled in clinical research that delivered by ourselves, and we have a large lab in Livingston which each and every day processes biosamples on behalf of global clinical trials across the world. The second pillar is the work that we do around real-world evidence. And it's really interesting, I think it was Tim who mentioned the need for evidence along the whole of the adoption journey, and we'll talk a little bit about that as we get into the content. The third pillar is the pillar that I'm very proud to lead here in the UK. And just to give you an idea, I wore the battle scars of collaboration. So my career has been built literally trying to set up collaborative working 25, 26 years ago. And in the last 5 years, we have set up 180 collaborative programs working hand in glove with the NHS, with HSNs, with HINs, with many people in this room. Last year, my clinical team delivered over 500,000 episodes of care into the NHS under the guise of collaborative working, just to show you the scale and pace of what can actually be delivered when we come together and collaborate. And then the last pillar that we offer, and this is probably one of the kind of best kept secrets, over 95% of NHS organisations already use our technologies, already use our platforms for things like hospital coding, financial planning, benchmarking, etc. And the COVID infection survey, again, almost 5 years ago to the day, believe it or not, Sir Patrick Vallance rang up my boss and said, Tim, we have a challenge. We need to know the circulating I rate across London, about 10,000 patients initially. And very quickly, Boris decided that we shouldn't just have a solution for London, we need a national programme. So we stood up 4,500 employees in a matter of weeks to deliver door-to-door swabs and blood sampling that affected the daily I rate, that when Boris would stand up and talk about the circulating I number each evening, that was our clinical team who were delivering that. And it was that work that helped us navigate our way out of the pandemic. So hopefully that gives you kind of a bit of sense as to what I call the right to play and why I believe IQVIA have a right to play in this space. A lot of what I do is to convince global pharma companies that the NHS is still an attractive place to come and do business. It is perceived as a really difficult market by global pharma companies. And that is evident through the lack of clinical trials or the falling number of clinical trials that we're having here. The second reason that the NHS is seen as difficult to do business, if we use NICE approved medicines as a proxy marker for uptake of innovation, there's two stats. Only 1 in 3 ICBs meet the 90-day mandate for availability of NICE approved medicine to their patients. That's the first mandate. The second challenge is that it takes 4 years and 2 months for the average ICB to reach 80% of the addressable patient to get access to that medicine and technology. So it's those two reasons why oftentimes the NHS is perceived as globally a difficult place to come and do business. Now, there are reasons to be cheerful. I'm a very optimistic person, so we have a really, really thriving med tech and health tech sector here in the UK. We have over 4,500 health tech companies originate here in the UK, employing 157,000 people and attracting £30 billion worth of inward revenue into the UK. The challenge is that whilst we're great at innovating and we're great at incubating, we're not so good at commercialization and landing and expanding, driving that adoption. So what's happening is we innovate here, we commercialize in other markets. We're going to the US, we're going to the Big Four, we're going to Canada, we're going to Australia. So I guess my challenge to the room is what can we do collectively to help those companies land and expand here in the UK? To do that, it's going to take a system-wide approach. It's going to take the methodology that Roland and others, Tim and Nicole have said. And a topic that's close to my heart is that if there is disparity in innovation, and we know there's laggards and there's early adopters, are we actually driving a bigger wedge in terms of healthcare inequalities? And it's just something I want you to think about as we go into the workshop today. So, collaboration, and a lot of this has been said, but I want to call out one or two little pieces here. So the first one is NHS and academia, they really need to come together more closely. And reasons are not just to think about job planning for the future, but also making sure that we're research ready and able to go make a fast start. And then the second thing is trials must be embedded into patient pathways. They're not something that happens over here. They must be along the whole part of the journey. The second aspect is around industry partnerships. I would say that there's often a nervousness in engaging with industry. That's just the reality. What we have here in the UK, we have the ABPI with a really, really strong code of conduct, and it's the envy of the world in terms of the way that we collaborate. And what I think we should do, we should really dig into that. And most of my career has been spent working with NHS leaders to help create the governance framework that allows us to collaborate with industry more openly and honestly. I also feel that we need to create a level playing field for those startups and scale-ups when it comes to health tech, and we all have a role to play in that. And things that we can do, like building an SME passport, that will help us to demystify funding flows within the NHS. The third element for me is oftentimes the uptake of innovation and adoption is not driven by policy, but it's driven by personality. How many times have you heard of a clinical advocate driving an idea across an area? We've got to get beyond personality-led uptake and adoption. We've got to move towards having a centralized policy that incentivizes and benchmarks the uptake of that adoption locally. And then the last thing is we do none of this without our clinicians. We need to involve our clinicians at every wheel and turn along the way. Now, there's a couple of comments I want to make here, particularly around you'll have seen this, the S-curve shape of adoption and the impact of innovators versus laggards. It is really important that we don't inadvertently drive and deepen healthcare inequalities by actually focusing on the early adopters and focusing on the innovators. And my challenge to life science colleagues in the room is oftentimes life science go where it's easy to go to. They go to the ITBs who they know are going to engage. And I would challenge life science companies to make sure you go where the greatest clinical need is, not where it's easy to go. In terms of clinician engagement and patient centricity, the two go hand in hand for me. And I think it was Nicole was talking about the idea of iteration, ideation, and prototyping and fast failing. That is absolutely key and imperative when we're thinking about how we actually come together and create solutions that put both the patient and clinicians at the centre. And I'm whistling through the slide because Ben told me I've got 5 minutes, so yeah. And I have unashamedly borrowed this slide from a good friend of mine in Health Innovation East Midlands, and this will be, again, things that both colleagues from West and East Midlands presented on. but it's the key role that the HINs have to play here. The HINs for me are a lightning rod. They're able to take that global to local innovation and make it work. We've also heard the term demand signalling. I also think that life science colleagues in the room can also help that demand signalling by being able to help the NHS understand their own data, understand where the gaps in care are, and then bring the innovation back. Now, I do want to finish on the case study. So something that is real, something that is tangible, because most of what we've heard this morning is kind of focusing on theory, okay? So this is a piece of work that I'm very proud to have led on with the Christie in Manchester. The challenge that came back from a pharmaceutical company was that they didn't feel that the medicines were reaching the patient population that they needed to. And when they did reach a patient population, those patients tended to be having stage 3 and stage 4 cancers, which were much later in the pathway than where they knew they were getting a better prognosis at stage 1 and stage 2. So in this, we worked really closely with the HSN, as it was then, not before it kind of rebranded. We worked closely with the Foundation Trust. We worked closely with the ICVs, and we worked closely with the pharmaceutical company. Now, what came through here is a number of key challenges. One is, initially, the challenge was on product, not pathway. And when we started to dig into this, the real issue was pathway, not product. And that's really super important. Things that we found, 1 in 5 patients were cycling through the system before they got a referral into the specialist centre. Second thing we found was, in areas of greatest healthcare deprivation, greatest socioeconomic deprivation, 30% of patients were presenting with stage 3 and stage 4 cancers. Now, what does that mean? Because very often what we then overlaid were transport links, and we found that the mobile screening centres were going nowhere near these areas. So what we started to do was to signpost it to where the mobile screening centres should go to. The third thing was around when patients were getting onto treatment, they weren't sustaining on treatment, and one of the reasons was issue with transport and issue with convenience. So what did we do? We flipped it into a home care provision, and we brought the care close to the patient rather than having to bring a patient into the hospital. And then the last one, we reignited the pathway, and we made people realise that, and by reignite the pathway, what I meant was breathe new life into it. There was a pathway already in place, but you can see from the very first one, the fact that 1 in 5 patients were cycling through 2 or more hospital trusts, that's what we needed to do. Now, I am here all day. Hopefully, what I've been able to do is to kind of turbocharge some thinking, and I'm really looking forward to the workshops this afternoon. But I do wonder if Ben's not shouting at me whether we can take one question from the room. Yeah.
You mentioned about the kind of lack of commercialization within, from like discovery across that. What do you think we can do better to help you commercialize those innovations that come through?
I mean, there's two things to that. One is we're really good at building bodies of evidence when we're looking to bring a new product to market, or we're looking at regulatory approval. But what we're not so good at is working together to create that real world generation of evidence, because what we should be doing is capturing the innovation and the impact that it has, not just from a clinical perspective and not just from a financial perspective, but also from an economic and a societal impact. And I think that is mind shift change that I think we're going to start to see, particularly with this government and particularly with the new ways of thinking with the 10-year plan, is societal impact of the pathway improvements that we can make. Hopefully that answers your question.
I like that you feel positive about the new government coming in and what they're going to be doing. That's great.
Well, I think we need to be positive because it's the only government we have at the moment. So, yeah.
Thank you.